I'd like to start our panel discussion with Q&A. If it's all right with you, Puneeth and Julia, we'll go by first names. Please call me Ticiana.
Yes.
And, just to kind of remind everybody, we're really having this event for patients with lung cancer, their caregivers, for survivors. So keeping in mind the patient perspective in some of our discussion, I think one thing that I wanted to ask you, Julia, to start out with was, you brought up a very important topic of biomarker testing in early stage lung cancer, given that for some patients, perhaps the strategy would be different. Could you outline from a patient perspective, what should they be talking to their doctor about if they have a diagnosis of early stage lung cancer and they're trying to decide, do they think that preoperative strategy with chemoimmunotherapy is a good option for them?
It's a great question, and it's actually a really important question to ask your doctors because it can get them thinking about it and make sure you get the right testing. The short version is, for people who have a lung cancer that's thought to be removable by surgery, about half of lung cancer will need what we call mutation testing, particularly for that EGFR mutation I mentioned. That one's the most common of the mutations we find in lung cancer, particularly for people with less history of smoking, but can happen to anyone. They really need very different treatment with these EGFR targeted therapies. So really that's the critical one right now. I will say, if you're able to get it, we always like to get our mutation testing as part of what we call broad next generation sequencing, which tests not just for EGFR, but for several hundred different cancer related genes. Many of these, we don't know what to do with them yet, I will admit, but there's a subset of them that might change how your doctor thinks about your upfront treatment. That's not required by official standard of care right now, the broader testing, but I think we're moving that direction. If it's available, it's nice to have. The other biomarker that's not officially required just yet when thinking about preoperative treatment, but I think is really helpful, is that PD-L1 level. That's a test that's done on your tumor biopsy. Again, if it's high, predicts for a better response to immunotherapy. And if it's really high, your doctor really should be, I think, thinking very carefully about trying to get immunotherapy into your regimen if it seems reasonable. So not required, but can help you have a more nuanced discussion. And definitely it's required if you're going to get this post-op. So you might be in a situation where you've already had your surgery, maybe you're recovering from surgery, and you're going to see your doctor and talk about post-operative therapy. Even if you didn't get this immunotherapy up front preoperatively, you can get it post-op. There's that 1-year regimen available if you're PD-L1 positive. So it's still useful to have that biomarker so you'll know all your treatment options.
Great, thank you.